speaker is Dr. Saumitra Ray, and I'll request Dr. Alok Rai to introduce Dr. Saumitra Ray. Dr. Alok Rai, please.
Thank you, sir. Good morning, all of you. Dr. Saumitra Ray is well known to all of us. He is a consultant in Woodlands Hospital, Kolkata. He is ex-professor Vivekananda Institute of Medical Sciences. He is vice president of the Cardiological Society of India. He pursued MRCP in UK and after his MD from Kolkata Medical College. He is specially trained in interventional cardiology at Royal London Hospital, London. Published multiple papers, review articles, and chapters in cardiology books in India and abroad. He is among the among top 8.1% of the 56,000 plus authors worldwide on cardiology. He is on the editorial board of Indian Heart Journal, International Journal of Diabetic Dyslipidemia, and he has represented CSI in international conferences. He is an acclaimed literary critic, debater, and orator, and today he is going to talk on PCI in multivessel disease status 2025. Over to Professor Saumitra Ray.
Thank you, Dr. Rai. Thank you, Dr. Manoria, for the very kind invitation and for the very kind introduction. Let me, is it full screen? Not at the moment. I'll go again. I hope this is full screen, is it?
Yes, sir.
Yes.
It's full screen now, yeah. So the subject is very day-to-day subject. We all face every day, the people of us like who go to cath lab. PCI in multivessel disease, what we are in a position in 2025. Now, when you talk about multivessel disease, in who is the patient? ACS, CCS, or asymptomatic patient? I'll say the asymptomatic at the end. And if ACS, he is a STEMI patient or non-STEMI patient or unstable angina patient. So take one at a time. I'm not going to tell you who is unstable and who is non-STEMI and who is STEMI. It's a wastage of time. Let's go to multivessel coronary disease when you are encountering a patient of ST elevation macular infarction. So, of course, we are talking about total revascularization versus culprit-only approach. Now, this was published about a year ago. It's a meta-analysis of 24 trials of 16,000 plus patients, and it showed that complete revascularization reduced all-cause mortality with any MI. Look, it is not just STEMI. With any MI, the p-value was significant. Cardiovascular mortality, MI, and MACE, and repeat revascularization was also significantly reduced. In STEMI patient, the point estimate for all-cause mortality with complete revascularization was 0.91, which was not very significant. That is important. Rates of stent thrombosis, major bleeding, and AKI were, however, similar. Immediate complete revascularization ranked higher than staged complete revascularization. This is another important thing. If we decide about complete revascularization, whether to do it during the index procedure or before hospital discharge or maybe within 4 to 6 weeks of hospital discharge, so it is the immediate which scored high. Now, the ACC recommendation came, you all of you know that about a month ago, not even a complete month, and they had the recommendation very clearly said in multivessel disease in STEMI. They said in selected and hemodynamically stable patient with STEMI and multivessel disease, after the successful PCI to the infarct-related artery, significantly stenosed arteries. Now, what is the significantly stenosed artery? Which you visually see as diameter stenosis of more than 70%, and it is 50% for left main. Very clear. Non-IRA is recommended to reduce the risk of death or MI, and that is class 1A. In appropriate patient with STEMI and complex multivascular disease, after this elective bypass for significantly stenosed non-IRA involving LAD or left main is reasonable. So here bypass, it is reasonable, it is 2A. Who are they? Complex multivascular disease or multivessel disease. Now, a selected patient again with STEMI and low complex MVD, low complex, who are not going for bypass. Multivessel PCI or significantly stenosis IRA at the time of primary angioplasty may be preferred over a staged approach that we have mentioned and shown in the previous meta-analysis, but it is 2B. In patient with STEMI complicated by cardiogenic shock, routine PCI of a non-IRA should not be performed. It is class 3. Class 3 can be of two types. One is no benefit, one is harm. Here it is harm, so don't do it. Management of non-infarct related artery in STEMI. So it is a summary of what I said. If it is cardiogenic shock, don't do it, harm. If it is hemodynamically stable patient, then CABG if it is a complex disease, or multivessel angioplasty if it is a low complex disease but is significant stenosis. But how would you assess the non-culprit lesion? Just by 70%, 50% lesion, coronary angiography, or you do intravascular imaging, or you do FFR, or non-hyperemic physiological testing like IFR, or non-invasive functional assessment. Let's take this study of frame AMI. Dynamic compare, they said culprit versus FFR guided. PAMI can complete, they said culprit versus angio guided. And what is the score? The frame AMI trial showed that all these 4-5 trials taken together, if you go by the FFR guided, these are the brown ones, they are always low, quite low compared to angiography guided. Whether it is primary endpoint, whether it is death, you see 2.1 versus 8.5, huge difference. Marginal infarction 2.5 versus 9, repeat reverse 4.3 versus 9. So this is the thing, FFR guided should be done, which reduces all the primary points by more than 50%. Hazard ratio is 0.43. P-value is 0.003. So you should use FFR while attempting second or third angioplasty after the PPI. Now, frame AMI subgroup, if you see, this is interesting. ST segment lesion, FFR, even if FFR guided, it's not very different from angio guided. But if it is non-ST, yes, there is a huge difference. So again, then it comes to our knowledge that if it is a PPCI, primary angioplasty you are doing in STEMI, FFR is not that important. But if it is non-STEMI, FFR is very important. So that is another trials thing came 2023 by Lee, etc. In patient with acute MI with multivessel coronary disease, the strategy of selective PCI using FFR guided decision making was superior to a strategy to routine PCI based on angiographic diameter stenosis for all the parameters, which is more applicable to non-STEMI than STEMI. The take-home message of the ACC 21, which is again endorsed in 2025, the stage percutaneous intervention while in hospital or after discharge, mind it again, of a significantly stenosed non-culprit artery with STEMI is recommended in select patient to improve outcome. Percutaneous intervention of non-culprit artery at the time of primary intervention is less clear and may be considered in stable patient with uncomplicated reverse of the culprit artery. So for STEMI, it is less clear. Non-STEMI, it is clear. Let's see non-STEMI again in a clearer light. What did he say? This ACC guideline 2025. In patient with non-STEMI SCS multivessel disease, bypass or multivessel PCI should be done. Disease complexity and patient comorbidity, class 1 recommendation. In stable patient with non-STEMI with multivessel, but without left main, who are not intended for bypass and undergoing culprit lesion PCI, PCI of significant non-culprit lesion, during the index procedure or as a stage is recommended to reduce MACE, again class 1. Physiological assessment of a non-culprit stenosis gives better result, but class 2B. And what is harm? In cardiogenic shock with non-STEMI, because of death or kidney failure, don't go for multivessel. For STEMI or non-STEMI, in cardiogenic shock, leave the patient after the primary angioplasty. Problem with non-STEMI, sir, you all know. In non-STEMI, you do not know sometimes which one is culprit. We do not know. In STEMI, it is very clear. In non-STEMI, sometimes we are confused which one is causing the trouble. Even if inferior wall, whether it is a circumflex 99% or RCA 99%, we are sometimes confused. So multivessel disease in hemodynamically stable non-STEMI patient undergoing PCI, complex reverse should be considered in 2A. If you see the multivessel versus culprit-only reverse, all the MACE, MI, all-cause death, everything goes in favor of multivessel unless the patient is in cardiogenic shock. Mild trial, immediate. Now, okay, we agree that we will do multivessel, but whether immediate or staged, you see the right-sided thing? One stage population has got much less MSCC, almost 50% reduction. Hazard ratio is 0.54, 50% reduction with a p-value at 0.004. So do it on the same sitting rather than bringing the patient after 3 days or 7 days. Fire trial showed the same thing. If you go here, if it is STEMI, again it is dubious. If it is non-STEMI, very clear-cut benefit. BioVask trial came only last year, immediate versus staged. Again, immediate versus staged. So STEMI, again, it is a bit unclear. Non-STEMI, again, you see immediate versus stage is a bit confusing, but the guideline says do it immediate for non-STEMI. For STEMI, you get every patient by its own merit. So recommendation for management of patient with multivessel, functional invasive evaluation of non-IRS severity is 2B, 2B for non-STEMI. In patient with non-STEMI and multivessel disease, where you choose bypass, significant left main with high complexity coronary disease, multivessel CAD with complex or diffuse disease, diabetes with involvement of LAD, multivessel or left main disease with left ventricular dysfunction. So diabetes, LV, heart failure to reduce ejection fraction, and complex multivessel disease with left main. Any two of the three go for bypass. That is going on for last 10 years, still valid true. Prognostic value of syntax. Now, syntax, if you do, the MACE decreases if you go by syntax. But if you see the management of non-culprit lesion in non-ST, this is the algorithm. I'm not going again. We have already discussed. Take-home message is complete reverse should be considered for patient presenting with non-STEMI. This should preferably be performed at the same procedure. The use of physiological measurement of non-infarct artery may be considered. Now coming to chronic coronary syndrome. Here the problems come, optimum medical therapy or at all there is revascularization. If revascularization, PTCA or bypass. And how we use the newer gadget. OMT versus reverse, again the ACC said, updated evidence from contemporary trial and said that normal LV function, triple vessel coronary disease, surgical reverse is reasonable to improve survival. A survival benefit with PTCA is uncertain. Reverse decisions are based on various things, including a heart team. Now, how to define this complexity? Is syntax good? Syntax is 2B. Because they said, again the SEC says, treatment decision for patient undergoing surgical reverse should include the calculation by STS scoring. The usefulness of syntax score in treatment decision is less clear because of inter-observer variability in calculation and there is no clinical variable. So syntax score is going off a bit. Now, these are the complexity. How do you see the things are complex? Of course, there is scoring on basis of that, and you know all these things. Now, revascularization when? To improve the survival. Remember, survival. When? In patient, left ventricular ejection normal, significant proximal LAD. You may improve survival, but 2B, not 2A, not 1. In patient with, again, normal LV, 1 or 2 vessel CAD, not involving LAD, proximal LAD, is not recommended to improve survival. Here, 3 is for no benefit, not for no harm. not for harm, but for no benefit. So this is a different kind of tree, a bit docile tree. Again, multivessel. Normal ejection, significant stenosis in 3 major coronary arteries, with or without proximal LAD. An anatomy suitable for bypass, bypass first, 2B. And if not suitable for bypass, then multivessel PCI, again 2B. And what is harm for survival? Who have more than one coronary arteries that are not anatomically or functionally significant. Coronary revascularization should not be performed with the primary or sole intent to improve survival. So, unless it is 70% or more, or FFR is positive, do not go by your eye estimate or by your passion or revascularization or intervention. Now, when to reduce event? Not survival, but event. It is a bit more lax in multivessel CAD. Either CABG or PCI is reasonable to reduce spontaneous MI, urgent revasc or cardiac, and that is quite good recommendation of 2A. Improve symptom. Patient with refractory angina with medical therapy, and there is coronary significant disease, you go for it, class 1A. But when you don't go, when it's free harm, in patient with angina, but no anatomic or physiologic criteria for revasc, don't go for any. So that is a less than 70% FFR, you have to do this, even for angina. So it's an algorithm. So that is the American, what happened to the ESC across the Atlantic on this side, 2025 CCS guideline, when the ejection is better. Functionally significant left main disease, you go for it, 1A. Functionally significant 3 vessel disease, improve survival, cardiovascular death and MI, class 1A. Functionally significant 1 or 2 vessel disease, improve long-term CV death and MI, not total survival. Ejection below 35. Markedly revasc along with GDMT is considered with coronary anatomy, life expectancy, comorbidities, and individual factor, class 1. For multivessel disease, CABG is better than medical therapy alone for long-term survival, again class 1. If CABG is not feasible, multivessel PCI, but it is 2B, unfortunately, not even 2A. Now, when PTCA versus CABG, Americans, in patient who require revasc for significant left main with high complexity CAD, always CABG over PCI, class 1. Who require revasc, but complex and diffuse CAD, syntax high, reasonable to choose between CABG over PCI, 2A. But multivessel CAD with the involvement of LAD, appropriate for CABG, CABG, not appropriate for CABG, poor candidate, PCI can be useful. Immediately the recommendation comes from 1 to 2A. And left main stenosis and lower intermediate complexity CAD, it comes to 2B in diabetics. Now, patient with previous bypass, in preference with previous bypass with a patent lemma who need repeat revasc, if PTCI is feasible, do PTCI, that is 2A, over CABG. Here PTCI is over CABG. Patient with previous CABG and refractory angina, LAD is happening for LAD, it is reasonable to choose CABG over PCI, 2A. In patient with previous CABG and complex LAD, may be reasonable to choose bypass on PCI, but we are not so sure which one is better, not enough data to be. The Europe, that is American, what the Europeans say for diabetic patient in CCS with multivessel disease and diabetes with failure of medical treatment, CABG again 1A. If it comes to multivessel disease or 3-vessel disease without diabetes, then CABG as well as multivessel PCI, both are 1A. CABG or PCI is recommended over medical therapy. And if you see down, insufficient response to guideline-directed medical therapy, if it is there, PCI is recommended to improve symptom, not survival, not event, but to improve symptom. What are the role of newer gadgets? Revascularization in patient with angina or equivalent, undocumented ischemia, and angiographically intermediate lesion. Use of FFR or IFR is recommended, very strongly recommended. When you don't do it, in stable patient with angiographically intermediate stenosis, FFR above zero point 0.8 or IFR 0.89, you should not go for PCI. No harm, but no benefit. What about intravascular ultrasound? In patient with intermediate stenosis in left main, IVUS is reasonable to help define lesion. Way. And in patient with coronary stain, IVUS can be useful for procedural guidance in case of left main and complex coronary. And OCT is the reasonable alternative to IVUS, 2A. So IVUS or OCT either. And that is also endorsed by the Europeans. And if you see that recommendation for functional assessment, FFR, IFR, QFR are class 1, CFR, HSR, CFC are about 2A, and routine wire-based coronary pressure assessment for all vessels is not recommended. It's when you are uncertain, you are intermediate. I am finishing with two very recent trials published last month with ACC, that is FFR guided PTCA compared with bypass surgery, final 5-year result of the evaluation 3 trial. And it multivessel evaluation, and it showed that the p-value is really not significant. So if you do it with FFR guided and multivessel PCI matches CABG, maybe the guideline will change next, because ACC guideline and these results were published in the same seminar, in the same conference. So they did not have the access to this knowledge. So that is the conclusion. And another trial came, the flavor trial, that is very interesting. That is FFR versus IVUS to guide your angioplasty, and it showed they are same. They are same. Whatever you have in your cath lab, be happy with that. Don't go for this and that. FFR and IVUS are the same. Some people are more conversant and expert in IVUS. Some people don't feel that so convincing. So primary outcome really don't matter. So that is the question. And once more thing that in the cath lab consideration in ACA, go for radial. That is the new recommendation, class 1A, go for radial. That is the last slide I will say, and that is the most complicated, most difficult side. I leave it to you. A multivessel disease detected by CT angiogram, patient is asymptomatic. The question comes, why did you do the CT angiogram? Nowadays we are telling that for risk scoring, whether the calcium is there, whether it is there and that. Sometimes in some jobs like pilot, some military jobs, they do it routinely. And sometimes people, moneyed people, they say, why doctor, please do something which you will know inside my arteries. And you do a CT angiogram in an asymptomatic patient. Great for prognostication. Fantastic. I'll increase your dose of statin. I'll increase your dose of anti-diabetic. I'll reduce your body weight. Calls for intensive preventive therapy. Definitely it is important. Never to go for revascularization if there is no symptom. Now I do not know. If you see a triple vessel disease, 80% lesion in LAD, RCA, and left circumflex, and patient is asymptomatic for whatever reason, whether he's stoic, whether he's stupid, whether he's insensitive, whatever be it, he's asymptomatic. Will you go for triple vessel angioplasty or bypass? What if evidence of big ischemic? And what if the patient is asymptomatic, but you do some test and get an ischemic chunk? Then what will you do again? I don't have answer. You might say, my respected chairpersons, all my colleagues over here, leave it to you. So that is my last slide. Shared decision making at the end of the day. Informed consent. Clinician provides the best available evidence for what are the options. Patient-centered care. It is, at the end of the day, you remember that you are doing the angioplasty to relieve the patient and not to earn money. Of course, that is an important thing, but that should be second point, not first point. And shared decision making is also very important. Our team approach, we should have some more cordial relation with our surgical colleagues. Instead of fighting and tug of war, we should have some sweet spot where we can conquer and post. So thanks to all.
That was a wonderful talk, Dr. Ray. My question is, what has changed in the 25 ACS guidelines?
What is?
In terms of multivessel PCI, what has changed?
It has changed in 25 ACI. It is not much change from 21. Now they are saying very clear-cut thing in cardiogenic shock. Don't look around. Just do the PCI and come out. Though there are some very recent trials contradicting, but again, they are very clear that cardiogenic shock, don't fiddle around. Do the PCI, come out and pray to the God. Number two, if it is a clear-cut case after MI, after STEMI, then, and it is not complex disease, go ahead on the same sitting. Don't wait for 3 days, 7 days, 4 weeks, 6 weeks. Go on the same sitting. That is number two. FFR, you can use if there is some point that whether I'll go for or not. Patient has already got a lot of dyes. The patient is already the radiation time is more. I have already done three vessel. So whether I'll go for a fourth vessel or a branch vessel, go for FFR. And if the FFR is, then you know that kind of thing. For non-ST, and if it is complex, then do the PPCI, wait, and go for CABG later on. For non-STEMI, same sitting, is you are more liberal to go ahead with multivessel angioplasty. FFR, you can use more liberally to each and every lesion, and that is the very clear cut they have said about this. So they are more prone to go for multivessel angioplasty, and their recommendations are going higher up.
Thank you.
Dr. Ray, what is the current status of drug-eluting balloon? Drug-eluting balloon.
Yes, sir. Yes, sir. Drug-eluting balloon is very much coming in vogue, particularly when it is an instant stenosis, particularly when it is small disease, small vessel disease, diffuse disease. And but one problem with the drug-eluting balloon, what I find, it is coming up again. It was there, it went down, it's coming up. Is the problem is that you are not sure that whether you will not require another stent to support the drug-eluting balloon-induced dissection. So the money, the budget comes always. And you know, all these government budgets, they are not endorsing drug-eluting balloon. They're giving only for the stent. So balloon has to come from the pocket in the first place, and you cannot guarantee the party or the patient that after the balloon, I'll come out with the balloon. I have to, may have to put a stent also additionally. So that is, I think, a bit difficult at the moment, but drug-eluting balloon is definitely going to change, particularly in the areas when you cannot go ahead with long-term antiplatelet therapy, dual antiplatelet therapy. In those patients, drug-eluting balloon has really hold very good promise.
And the current status of bioresorbable scaffolds, they came, went away. So what is the current status?
Again, sir, it is coming and going. We know that it happened in India very much, and sometimes it is said that only stent should remain in the world is bioresorbable stent, but somehow they did not keep their promise. But it is coming back again. People are trying to get rid of the metal. That is for sure. Whether it is by balloon, whether it is by bioresorbable, we are trying to get rid of the metal. But I think bioresorbable will be there. We are still waiting for good designs.
What is your experience with intravascular lithotripsy for calcified lesions or rota?
Sir, I don't have any personal experience, but my colleagues, because I do in high volume centers, and some colleagues are doing it, and the initial results are very, rota is a bit old, but intravascular lithotripsy, even in our Manipal hospital in Nakuria, quite a few have been done, and people are getting amazed. They are saying, oh, that's so fantastic thing that we never believed that the artery can be so nicely seen, but I didn't do it personally, I can't say, sir.
So thank you, Dr. Ray. So we now pass